if we may. I hope you can hear me at the back. I'm a bit quietly spoken, I'm afraid. Welcome to Teesside University, both colleagues and visitors in the room, guests in the room, and also I think we have quite a few people joining us online. So you're all very welcome to this exciting event, which is Professor Harrison's inaugural lecture. My name's Steve Cummings. I'm the Pro Vice Chancellor for Research and Innovation here at Teesside, and it's a great pleasure to introduce Samantha's lecture this evening. I'll just give a brief resume of Samantha's career, and then we'll get straight into the lecture. So I'm obviously delighted to introduce Samantha's lecture. Samantha is a professor in respiratory rehabilitation here at Teesside University in our School of Health and Life Sciences. Samantha graduated in 2006 from Northumbria University with a joint BSc Honours in Psychology and Sports Science. Then in 2009 she went on to complete an MSc in Physiotherapy at Leeds University. Alongside this she began working at Glenfield Hospital in Leicester in the Pulmonary Rehabilitation Department, where her time was split between research and clinical service. Samantha was awarded her PhD in 2014 from the School of Psychology, the University of Leicester. Her PhD comprised a mixed method study exploring illness perception following an acute exacerbation of chronic obstructive pulmonary disease. That was to inform tailored strategies to enhance pulmonary rehabilitation. Then in 2013, Samantha moved to Toronto, Canada to complete her international postdoctoral training in respiratory medicine and pulmonary rehabilitation. And that was at the West Park Healthcare Centre. And during this time, she also delivered teaching in cardiorespiratory and in the Department of Physical Therapy at the University of Toronto. Then in 2015, Samantha returned to the UK and commenced a position as Senior Lecturer in Health Sciences here at Teesside University. She was awarded her readership in respiratory rehabilitation in 2018, and Samantha's research interests are primarily in the area of respiratory medicine, specifically COPD, cardiothoracic surgery. Her current research projects include the use of virtual reality for rehabilitation and the impact of balance training in individuals with COPD. Samantha has over 40 peer-reviewed journals and has secured in excess of £3 million in external funding. She's also a peer reviewer for several renowned journals, including Thorax, Chest, European Respiratory Journal of Chronic and Respiratory Disease, which are all journals which have rejected my papers in the past, interestingly. Samantha is also the co-lead for the Council for Allied Health Professions Research Network North East of England, and is an executive committee member for the Physiotherapy Research Society. She is currently working in the cardiothoracic surgery team at James Cook University Hospital to develop and refine and enhance recovery services. Please join me in welcoming Samantha as she shares more insights into her career and work. Samantha, thank you.
Thank you very much for that introduction. I promise I didn't review those papers. Good evening. Thank you all very much for coming. It's lovely to see so many familiar faces. So my name is Samantha Harrison, and the title of my talk is Take a Deep Breath and Find Your Balance. So during this talk, I'm going to take you on my career journey, telling you a little bit about my inspiration for becoming a physiotherapist. I'll talk about balancing two disciplines, so namely physiotherapy and psychology. I'm going to talk a lot about the people that I've met and the opportunities that have led to me becoming a clinical academic. I'll introduce you to my research topic, which is respiratory rehabilitation, and I'm going to focus very specifically on my research, which focuses on people who have chronic obstructive pulmonary disease, and I'm going to talk about balance, impairment, and potential solutions in this population. And I'm going to finish up by outlining my future plans. So those of you who know me well probably won't be surprised to learn that I knew what I wanted to be when I grew up very early on, and that was an Olympic gymnast. So I used to watch repeats of Lilia Pokopayeva winning the women's all-around Olympic final. But after a number of falls from beam and a few heart-stopping moments from my parents, it seemed that I wasn't destined to follow in her footsteps. But I was really interested in sport, and I started to consider other career options in sports. So when I was 13, I announced I wanted to be a physiotherapist. My granddad, pictured on this slide, agreed that I was certainly bossy enough, and he actually bought me a book on the human body to get me started. So given that I'd started so early, it might come as a little bit of a surprise to learn that I got a grade D in my AS level biology. Not to be deterred, I pursued psychology as my science instead, and achieved a joint honours in psychology and sports science from Northumbria University. I really enjoyed my course, and I wondered if I might want to be a psychologist. But after applying for what felt like hundreds of jobs and receiving an equal number of rejections, I returned to my original goal to be a physio. And I applied to enrol on the pre-registration Masters in Physiotherapy course at Leeds Metropolitan University, which is now of course known as Leeds Beckett, so I'm showing my age. And my application was turned down without interview. So where did this leave me? Well, apparently we make 35,000 decisions a day. But every now and then we're faced with making a big decision that can shape our life experience and the direction our lives are going to go in. So has anybody here read the book, The Midnight Library by Matt Haig? Nobody, just you, Dan. Oh no, a couple of people. I confess that I actually haven't read the book, but my husband Dan has, he's told me all about it. And the story suggests that between life and death, we all have a library consisting of books that detail different lives and paths that we could have chosen and taken. And somewhere in my library is the life of me as an assistant prison psychologist. Because in the same week, I received a phone call from Gartree Prison in Leicester, informing me about an opportunity to be a prison psychologist working with Category B offenders. And in the same week, I had a phone call from Leeds Met, letting me know that a place had come available on the physiotherapy course. So as we now know, I chose to lead the life of a physiotherapist, and for the next 2 years I was known as Sean Clements, because that's the name of the person who didn't turn up to enrol in the course. So I began my physiotherapy training in 2007 at Leeds Met, and this is actually the same year that the smoking ban in public places came into effect in the UK. And physiotherapy wasn't quite as glamorous as I thought it was going to be. I certainly wasn't running onto sports pitches and healing what looked like life-threatening injuries in a number of seconds. But instead, I was helping people mobilise to the toilet, repositioning people to prevent bed sores, and checking out pots of sputum or phlegm. But it was during my course that I really developed an interest in health, and very specifically in the health of older people. Now at the moment, the media and news is absolutely littered with headlines like this one. So it probably comes as no surprise to learn that currently there is a shortage of physiotherapists. In fact, the CSP, the Chartered Society of Physiotherapists, are actually lobbying for NHS contracts to be offered to new graduates in the same way that they are for nurses. But in 2006, it was a really different story. More than 50% of physiotherapy graduates were unemployed 6 months after qualifying. And in 2009, when I qualified, job opportunities had improved, but only slightly. And it's perhaps because of this context that I applied for a job on a 12-month fixed contract as a research physiotherapist, not really knowing what a research physiotherapist was. The position was at Glenfield Hospital in Leicester, and it was a split post. So I was working part-time on a research study, which was led by Professor Mick Steiner, and part-time delivering the Pulmonary Rehabilitation service, which is led by Professor Sally Singh. And I didn't really realise at the time what a special opportunity this was, because by being embedded in the clinical service, I had access to patients for recruitment. It meant that research ideas were stemming from the clinical population, and I had a direct link for impact. And 14 years later, these positions are still really rare, but they're absolutely necessary to build research capability and capacity within allied health professions. And it set me up perfectly to do a PhD. And I'm really grateful to Sally Singh for offering me the opportunity to do a PhD, because to be absolutely honest, after that grade D, it's not an opportunity I would have sought out for myself. And it also gave me a chance to revisit my interest in psychology. So I did my PhD under the supervision of Sally Singh, who is a physiotherapist by background, and also Professor Noel Robertson, who's a clinical psychologist by background. And very briefly, my PhD comprised of 4 main bodies of work. So I sought to understand the experience of having an acute exacerbation of COPD. I tried to understand the efficacy of pulmonary rehab on improving mood. I identified patients who had different illness schema following an exacerbation to see if we could predict whether or not these people would attend pulmonary rehabilitation. And I tried to understand in detail why some people would decline a referral to pulmonary rehab after an exacerbation. And by the time I'd finished my PhD, I knew that I wanted to pursue a career in research. So I started to look at postdoc opportunities, and I also thought that I quite fancied a stint living abroad. And this was very much a case of who you know and not what you know. And lucky for me, I know the 5 people on this slide. So Dr. Rachel Evans, Professor Mike Morgan and Sally Singh introduced me to Professors Dina Brooks and Roger Goldstein, who are based at West Park Healthcare Centre in Toronto. And Dina and Roger offered me a postdoc position over there. And luckily, my husband Dan was on board. So we rented out our home in Castle Donington, and we moved into a basement apartment with a family that we'd never met in a city that we didn't know. But we fully embraced life in Canada and had a wonderful time. But I did do a little bit of work too. So I had the opportunity to continue looking at emotional impacts in people with COPD, and I also looked at the appropriateness of some traditional psychological therapies for people with COPD. I also had the opportunity to begin a programme of work which was started off by Marla Beecham, looking at balance training in people with COPD, and I'll talk about the studies on the right-hand side of this slide a little later on in the presentation. So it was a really difficult decision to move home after we'd been in Toronto, but after 2.5 years, we did move back for the pubs, the rugby, and my first permanent academic position at Teesside University. And when I moved to Teesside, one of the first people that I met was Professor John Dixon, who's since retired. But John really encouraged me to reflect on what I'd achieved to date and to consider some of the gaps in my CV so that I could really be strategic moving forwards in my career. And to be honest, this isn't really something that I'd done before. I'd always considered my career to be quite serendipity. But it turned out that I had a number of papers, I had a number of small grants awarded, but I hadn't had a lot of opportunity to undertake leadership roles. And undertaking these types of positions was a really great way to build up a network of collaborators in a region that I hadn't previously worked in before. One of these roles is as co-lead for the Council for Allied Health Professionals Research Network, or CAPA, in the North East Hub, and I'm really lucky in that I've been able to do this position with friends and colleagues. So for 5 years with Professor Cormac Ryan, and more recently with Dr. Jenny Naseby. And as part of the North East Hub, our aim is to increase AHP research awareness and capacity in the region, and to provide support for grassroots researchers. So these are people who are just dipping their toe into research for the first time. We offer 2 annual events that can take many different forms. So they might be skills workshops or research within a specific clinical area. And we also offer a small grant scheme which has funded now 40 AHPs to date to undertake a small piece of research that directly impacts clinical practice. And certainly supporting AHPs and trying to build research capability and capacity is something that I feel very passionate about and do my very best to encourage. But it hasn't always been easy. Since I've moved to Teesside, I've had a number of career breaks. So I've had 4 pregnancies, and sadly we've lost 3 babies who we've named Molly, Dylan and Owen. And in fact, we organise an annual 5K run in their memory. We do this in collaboration with Darlington Harriers, and it's to raise money for the charity for Louis, who support families after child loss. But at the time I received confirmation that I had my professorship, I was actually nursing my then 6-week-old baby daughter, and never have I felt less like a professor in my life. So I wanted to share with you this tweet that I posted at the time, because it received over 10,000 likes, and to put that into context, a popular tweet of mine usually contains a picture of my dog and gets about 40 likes. But it even had its own hashtag what a professor looks like. And I think they're referring to the fact that I'm female and I have a family, and not that I drink pints of Prosecco, because I promised that the glass wasn't as big as it looks in this picture. So although my title is Professor of Respiratory Rehabilitation, most of my research focuses on people who have chronic obstructive pulmonary disease, or COPD. And I imagine most people sitting in this room and watching online have heard of COPD, but it really is the Cinderella of chronic diseases, because it just receives so much less attention than other chronic conditions like asthma, stroke, heart disease. But as of November last year, it was the third leading cause of death in the UK, and in case you're interested, COVID-19 was the 8th. And a few familiar faces have sadly passed away with COPD. Now, Amy Winehouse might come as a little bit of a surprise because she's so young. But sadly, she didn't lead a particularly healthy lifestyle. She smoked very heavily, and in 80% of cases, COPD is caused by smoking. So these maps show the prevalence of COPD across the UK, and specifically in the North East region. The darker the colour, the greater the rates of COPD. So we can see that in the north of England we have the highest rates of COPD, and specifically in Middlesbrough we have some of the highest rates of COPD compared to anywhere else in the country. And this is probably reflective of socio-economic deprivation, because deprivation is of course linked with smoking behaviour and also industrial exposure to noxious substances. So people with COPD will usually present with breathlessness, especially on exertion, coughing and also sputum production. They'll also have a number of other comorbidities usually, including things like heart failure, diabetes. The effects of the disease can often result in psychological symptoms such as anxiety and depression, and it does have a systemic impact, so it can have wider physical symptoms such as pain and poor balance, which I'll talk about a little bit more obviously later on. It is a progressive disease, meaning there's no cure and it will get worse. And the trajectory is punctuated by these acute episodes called acute exacerbations, which will often result in an admission to hospital. So an acute exacerbation is defined as a sustained worsening of the patient's condition from the stable state and beyond normal day-to-day variations. They're characterised by increased breathlessness and also productive cough, which usually means you're coughing up phlegm that's this really lovely shade of green. So if breathlessness is the symptom most commonly associated with COPD, then why should we care about balance? So I'm not sure if anybody remembers this news article. It was actually published in The Guardian and the Daily Mail in summer last year. And it reports a study that was conducted in Brazil on over 2,000 people. And it found that people aged between 50 and 75 years who couldn't stand on one leg for 10 seconds were 84% more likely to die in the next 10 years. So I wonder how many of you are going to go home and try that. But it just shows that whether we have COPD or not, balance is really important in determining whether we are able to live a healthy and long life. So also balance and unsteadiness when we're walking are some of the main risk factors for having a fall. And the other factors listed on these slides, it's by no means a definitive list, but other factors linked to falls include being physically inactive, having weaker muscles, cognitive impairment, being on numerous medications, having comorbidities, and being of an older age. Now, how many of these risk factors do you think are also associated with having COPD? So the answer is, of course, all of them. So it's perhaps not surprising that people with COPD have a 4 times greater likelihood of falls than healthy adults of the same age. And in fact, performance is worse than healthy controls on measures of balance. In consultations with people with lung disease, they described feeling unsteady, both inside and outside the home, and this led to activity avoidance and feelings of fear and embarrassment. And as with most outcomes, having an acute exacerbation of COPD has a detrimental effect on balance. So this was a study that I conducted as part of my postdoc training in Canada, and I assessed balance before an exacerbation and looked at the short-term effects and the immediate effects. And I found that balance was reduced 7 days following an acute exacerbation, and in fact balance was still reduced even 1 month later, although there had been a small amount of recovery. So we know that balance is impaired, especially after an acute exacerbation, but we don't really understand why. So Dr. Kirsty Loughran, who did her PhD with me, sought to understand some of the mechanisms underpinning balance impairment. She did a meta-analysis of correlations between balance and quadriceps strength and found that strength does play a role in balance, but of course there must be other factors at play. So she also did a large secondary data analysis and found that the greater the severity of pain, the greater the probability of falling. And if we have a look at this graph at the bottom of the slide, let's see if I can get my pointer on, we can see that falls in people with COPD are shown in blue, falls in controls are shown in red, and across this x-axis we have increase in severities of pain. And we can see that there are more falls in people with COPD across all severities of pain, and in fact 39% of people with COPD and severe pain will fall in the following 2 years. Jeanette Morris, who's also doing her PhD with me, is actually seeking to develop an intervention specifically for people who have COPD and pain, and in future it'll be really interesting to see what kind of an impact that type of intervention has on balance outcomes. So pulmonary rehabilitation is recommended for everybody who has chronic breathlessness, symptoms of breathlessness, and it is the best evidence-based intervention that we have within the entire discipline of physiotherapy. It consists of exercise and disease-specific education. It's been proven to be clinically and cost-effective, but the emphasis is on breathless symptoms, and currently balance training isn't included. And we know from previous research that pulmonary rehab without balance training has very little effect on a person's balance. We also know that less than 50% of those people who refer to pulmonary rehab actually complete the programme, and by adding in balance training, we're unlikely to make it any more attractive. So this study, which was published in Chest by Marla Beecham, was the first study which looked at delivering balance training as part of pulmonary rehabilitation for people with COPD. Marla recruited 39 patients with COPD who were at risk of falls, meaning they'd had a fall or a near fall within the previous 5 years, and they were randomised to receive either 6 weeks of pulmonary rehab with balance training or usual pulmonary rehab. So what did that balance training look like? Luckily, it didn't look anything like this. Instead, it consisted of things like walking whilst turning your head to look either side, standing on one leg, standing up and sitting back down in a chair, throwing and catching a ball to move you outside of your base of support, standing on different surfaces, and strengthening exercises such as side leg lifts. So 30 minutes of supervised balance training was delivered 3 times a week for 6 weeks, and it was delivered concurrently with pulmonary rehab to groups of patients in 2s or 3s. The training focused on the subsystems of balance, biomechanics, transitions and gait, because previous research found these subsystems to be most impaired in people with COPD. And progression was individualised, and it was based on time and stability criteria. So for example, if a person was able to stand in narrow stance, so with their feet together easily for 30 seconds, we might make that more difficult by asking them to stand in that position for a minute, or asking them to close their eyes or stand on an uneven surface like a foam block. And compared to controls, The magnitude of improvement in the intervention group was greater for balance, which was assessed using 2 balance outcomes. So it was that's not going to work over there, but it was assessed using the Berg Balance Scale and also the Balance Evaluation Systems Test, known as the BEST test. There were improvements in physical function, which was assessed using the Physical Function Subscale, the SF36, and in functional lower extremity strength, which was assessed using the 30-second sit-to-stand test. Interestingly, there were no differences in balance confidence, which was assessed using the Activities Balance Confidence Scale. And I think this is because balance confidence is something that's really ingrained and very, very difficult to change. The green ticks show the minimal clinically important difference. So this is the smallest amount of change which is meaningful to patients. And we can see that the MCIDs are observed in the intervention group for all outcomes. If we just take a closer look at the subsystems of the BEST test, we can see that the greatest improvements were in the subsystems of balance, biomechanics, transitions, reactive control, and gait. And this is actually a criticism about this specificity of balance training, because it's perhaps not surprising that the greatest improvements were seen in these subsystems, given that these were the subsystems of balance that were specifically targeted based on research that had found them to be most impaired in the population. So it indicates that possibly you might be able to train somebody, for example, to stand better on one leg, so they are able to stand better on one leg, but that doesn't necessarily mean that they're less likely to have a fall when they're out and about doing the shopping, because of course different balance strategies are being used. And it also raises the question as to whether or not balance training is meaningful for individuals with COPD. So as far as I'm aware, there hasn't been any research done interviewing patients to explore their views on balance tasks. But Dr. Daniel Tuff, who did his PhD with me and is now working down in Lincoln, he did a mixed method study which included people who had undergone thoracic surgery for a diagnosis of lung cancer. And there is, of course, quite a big crossover between the two populations. Very little is known about balance in this population, so this was a really novel study. And he found that balance performance was less in people post-surgery than in healthy controls, and particularly there were deficits in the subsystems biomechanical constraints and postural responses, so very similar to people with COPD. But importantly, when he interviewed patients and asked them their views on the balance tasks, they found them to be really arbitrary. So for example, one patient said, it's not something that is in normal life, you know. If you go to Asda, you don't stand on one leg or with your eyes closed. So this really raises the concern, is balance training meaningful for individuals? Because if it isn't, they're really unlikely to engage in a balance training intervention. And we'll come back to that point a little later on. But to address the issue of whether balance training actually improves balance, but does it in fact reduce falls, there's a really large randomised control trial underway. 9 sites are involved across 4 countries, including Canada, Australia, Portugal, and we host the site here in the UK. We're doing this in partnership with our local NHS trusts. And unfortunately, recruitment had to stop early for this trial because of all the disruptions of COVID and the different guidelines that were put in place in different countries. But 258 patients consented, 41 of them at the UK site, and the analysis is currently underway, so hopefully we'll have the findings from this study to report very soon. So it seems that balance training works. It's improving balance in a lab setting, in a research environment, but can those findings be transferred to a sustainable clinical service? So as part of my postdoc, I did a prospective single group longitudinal study, and it included the healthcare professionals who are responsible for delivering pulmonary rehab at West Park Healthcare Centre. So this table just shows the actions that we took to try and effectively translate what we knew from a research setting into clinical practice. So we delivered an hour-long session, training session regarding the benefits and practical applications of balance training. We assisted with those balance training sessions. The programme development was led by the healthcare professionals, but the research team was there to make sure that the balance training was being delivered in a way that was consistent with the evidence. The programme logs were developed by the healthcare professionals, And we provided the brief best test results to allow some feedback on performance. And we think all these actions resulted in increased knowledge and awareness of the benefits of balance training, increased trust and rapport between the clinicians and the research team, increased feelings of ownership, and increased motivation. So in this particular study, a staff to patient ratio of 1 to 3 was used, but a ratio of 2 to 11 has since been shown to be feasible. And improvements in balance outcomes were equivalent to those that were observed in Marla's randomised control trial. We also did a focus group which included 6 of the healthcare professionals to try and ascertain their views on the barriers and what potential strategies might be used to overcome these when delivering balance training. And concerns were raised that the balance training actually distracted from the usual pulmonary rehab programme, but we did see improvements in some of those traditional pulmonary rehab measures such as exercise capacity and health-related quality of life. And there were also worries about time constraints, space and staffing. But a lot of these could be overcome by delivering balance training twice weekly as opposed to 3 times weekly, and this has since been shown to be effective, by introducing a home programme early, by providing visual aids to really promote independence in those higher functioning patients, and by considering the environment, making the environment safe, so less staff were perhaps required. But despite all of this, there's still an awful lot that we don't know. We don't know why balance is impaired fully or how we might personalise a balance training programme. We don't know how to encourage uptake to a balance training programme. And we certainly don't know how to ensure that balance training is sustainable, so in other words, that it fits into the everyday lives of people who have COPD. So with all this in mind, I applied for an NIHR Advanced Fellowship for the value of £1.1 million to co-create personalised, multifaceted balance training to be delivered alongside pulmonary rehab and reduce falls risk in people with COPD. And it's an extremely happy day indeed when you get an email from the NIHR with the 5 words, "I am pleased to inform you." And I really wouldn't have been successful in being awarded this fellowship without the support of my mentors, so Professor Dennis Martin, Eileen Kaner, Tim Rapley and Jamie McPhee. So the first piece of work that we've undertaken as part of this programme of research is to run comic-based art workshops with our patient and public involvement members from Breathe Easy Darlington. So we did this activity to really try and introduce the programme of research, to build a trusting relationship between the research team and the PPI members, and to really try and understand what it's like to live with chronic breathlessness. So I'm not sure how well you can see the images on the screen, but the illustrations really show people who are feeling quite unwell. They're sweating, leaning against objects, and in subsequent discussions about these illustrations, people described this overwhelming sense of losing control of their body, of feeling very disorientated and steady, and this led to feelings of fear and shame. And really this work has prompted us to rethink how we frame balance. Perhaps it's better framed around a sense of control. So these findings have really fed into our research programme and of course our intervention development. And I should say thank you to Dr. Julian Lawrence, who's a professional cartoonist, and he actually led these comic-based art workshops which were done online during COVID. They also resulted in us developing a project logo, because let's face it, no project's ever going to be a success without a good logo and a good acronym. And I have to thank my husband Dan for the acronym. He came up with BPURL, so Balance and Pulmonary Rehab. So our second programme of work that we are currently undertaking is a systematic review, and this is looking at interventions which assess balance outcomes to see if these interventions are effective at improving balance. We identified 27 studies, but we're currently updating the review, so it's likely there's going to be a few more. And 7 of these studies were rated as very promising, meaning that they improved people's balance. Within these studies, we identified 11 promising behaviour change techniques. So these are active ingredients or components of the interventions that might be useful in terms of improving balance. And we asked our PPI members to rank these behaviour change techniques in terms of importance. And the 4 that they identified as being most important was that balance training was delivered by a credible source, and in most instances this was a physiotherapist. That clear instructions were given on how to perform the behaviour, so in this case balance training. A demonstration was given of the behaviour, and information about health consequences were provided. And I find this bottom one really quite interesting. So the members wanted to know why balance was impaired and how the training was going to improve their balance. So overall, this research programme consists of 3 stages. They're all being conducted in partnership with our local NHS trusts. And the first 2 stages are focused on personalising balance training and how we might encourage attendance and sustainability. So I've already mentioned the systematic review. We're also doing a physiological study focusing on neuromuscular impairment. So we're doing a series of neuromuscular assessments in people with COPD and healthy controls to compare, and we're also doing associations with balance outcomes. But of course, physiology is only one part of the puzzle. So we're also conducting interviews and doing observations with people who have COPD to try and understand some of the psychosocial and environmental factors that may contribute to poor balance and falls. Stage 2 involves synthesising all the findings from stage 1 and co-creating balance training with stakeholders, clinicians, patients and members of the games and creative arts industries. And by involving members from the games industries, we really hope to be able to future-proof this intervention. So we want the intervention that we develop to be something that could potentially in future be delivered digitally if that seemed appropriate and was needed. Stage 3 will consist of a mixed methods pilot randomised control trial to see if all stages of the study can run smoothly together and to provide an estimation of a sample size. So at the moment, we don't know what the balance training intervention is going to look like. But if we think back, one of the criticisms of balance training in the past has been that it doesn't reflect everyday activities. So it might be that balance training is best aligned with normal everyday activities. So some of our previous work has involved delivering dance to people with chronic breathlessness. And this project was led by the Life of Breath. Again, it was done in collaboration with members of Breathe Easy Darlington. So it was a small study. It only included 10 members, so we certainly can't say with any confidence whether dance led to physical and psychological benefits, although it did look promising. And we did in fact see some improvements in the TUG, which is the timed up and go test and is a measure of balance. But I think the biggest win was that this project has had a lasting impact on the community. So 3 years later, and despite all the disruptions of COVID, dance is still being delivered by members of Breathe Easy Darlington as part of their once weekly exercise programme. Walking football is another potential activity, and we're delivering walking football in collaboration with Monty Towers, who is our walking football coach, and North Riding County FA are also providing some support through the scheme Shape the Play. So Callum Bradford, who is currently doing his PhD with me, is looking at the potential of walking football as a maintenance activity to deliver following pulmonary rehabilitation. And it might also have some benefits in terms of improving people's balance. So I just want to draw your attention to this photograph on the bottom of the slide. I can enlarge it for you. And specifically, I would like to look at the body position of this lady in blue. Now, I think this body position is absolutely remarkable, considering not one member of the group, they'll back me up, could confidently stand on one leg and circle their ankles during the warm-up. And I think it just highlights beautifully how walking football is a naturally occurring activity that can really challenge people's balance. And we observe lots of balance strategies during the walking football programme, so things like bending down, picking the ball up off the floor, turning, lots of step-in reactions. And that brings me on to my final slide, so I hope you'll forgive me if I finish off with a few acknowledgements and thank yous. I would like to thank my husband Dan for his continued support, even moving countries with me so that I could pursue a career in research. And of course my beautiful daughter Lois, who's our hope and joy even on days like this. I'd like to thank my parents who've given me every opportunity to achieve my goals and ambitions. I'd like to thank members of Breathe Easy Darlington who make sure that the research that I do is relevant for people with chronic breathlessness. I'd like to of course thank our funders, and as well as everybody I've mentioned in this presentation, I'd like to thank colleagues from Glenfield Hospital, West Park Healthcare Centre, the wider respiratory community, and of course colleagues at Teesside University, and specifically the Centre for Rehabilitation and Professor Dennis Martin, who just make it a pleasure to turn up for work every day. And finally, I'd like to thank Sean Clements for not turning up to the physiotherapy course and allowing me the opportunity to embark on this really rewarding and enjoyable career. And of course, thank you all very much for listening, and I'll leave you some references.
Thank you, Samantha, for an excellent and really informative talk. We'll have an opportunity for some questions. I think Dennis will be pleased there was such an old photograph there of him. But if there are any questions in the audience, if not, there may be some online. But we have a microphone, so please put your hands up if you have any questions.
Oh, no.
I can just shout. You're all right. What a brilliant talk. Thanks for that, Sam. Fantastic. I guess I'd love to hear how do you think the exercises that you're showing will change balance in your COPD population? Is it purely to do with sort of that physical thing of improving strength, or is there something deeper to it?
I think strength is certainly part of it, and I think that's what Kirsty showed in her systematic review, but I do think that's a small part of it. I think there's lots and lots of other factors that are at play. So hopefully by doing the neuromuscular assessments we can see how much nerve conductivity plays a role, possibly bone health as well is something that we might be looking at. But I do think, and it's been really overlooked even in older adults, let alone people with COPD, the social and environmental factors, I think they play a huge role in falls. And so currently there's been very little ethnographic research done in this population to try and understand what it's really like to live with the condition. And I think those types of insights will really help us shape a balanced intervention that fits in with the lives of these individuals.
Thank you.
Thank you.
Can I ask a question?
Of course.
Maybe slightly technical, but obviously the larger study, and I suppose related to Cormac's questions, is there any attempt to stratify the cohort of people you're studying based on age, sex, obesity, any or because clearly those things may confound some of the
Definitely, yeah. We'll need to control for those sort of confounding factors. So as well as the ones you've mentioned, pain levels might be important. That's something that we're measuring. We're also measuring somatosensory information, so proprioception within the foot, to see if that actually has an impact as well. But interestingly, sensory orientation, the subsystem sensory orientation is relatively well preserved in people with COPD. So we don't think proprioception and sensory problems are the answer. It seems to be much more focused on those sort of biomechanical transitions, and it might just be the way that people are doing these movements, because they've had to adapt these movements because of potentially stiffening around the thoracic region. So all these sort of things come into play. So I guess to answer your question, yeah, definitely we'll be considering controlling for all of those variables.
Would you have three? So I'll just ask one and then if we've got time. How might how might support these patients with perceived losses, wholeness, loss of certainty, loss of control, loss of freedom to act, and loss of the familiar world?
That's a really good question, and I'm not sure I know the answer, to be honest. I think it would be interesting if those sorts of themes are identified during those observations and subsequent interviews, and if those issues are picked up. To be honest, I don't have the answer of how they would be addressed, but I guess that's something that we'd have to look into. I think there was a question at the front here.
Is there a definitive diagnostic tool for COPD, or is it a general coverall for anybody who turns up with breathlessness? The reason I'm asking this is quite simple. A year ago, I had a stroke. I now take 8 different drugs a day. And one of the main side effects of 5 of those drugs is breathlessness.
Mm-hmm.
And I've never suffered, other than a slight asthmatic condition when I was very young. But during my hospitalisation and everything else, I later found, or they discovered later on, that I had a slight shadow on my lung. Nothing serious. And immediately I've been told I've got COPD.
So usually a diagnosis of COPD, and we do a test, a lung function test, or it might be called spirometry. And we're looking to see whether you're showing an obstructive pattern. So whether you have a reduction in your forced expiratory volume, so that's in 1 second, so that's how much air you can get out in that 1 second. And we also look at your vital capacity, so that's how much air you can keep in your lungs altogether. So usually when you have a diagnosis of COPD, somebody will have done a lung function or a spirometry test with you and been able to talk to you about those values.
But there is no direct diagnostic tool for saying you are COPD. It's a combination of...
No, you're absolutely right. Yes, it's a combination of factors. So it'll be the symptoms that you present with, as well as your lung function tests. Yeah, I hope that helps. Yeah, thank you.
Explain something.
Is a microphone or can you
You want the microphone?
No, I'm okay. I'm okay.
I can hear you.
So thank you very much for your presentation and congratulations for your grant and for becoming a professor. I have been following your career for many years.
Thank you.
Since the time you were a student at Leicester.
I know.
You were very fortunate because you were at Leicester, which is the Mecca here in UK and in Europe probably.
Mm-hmm.
So my point is that is lack of balance prevalent specifically in COPD, or does this happen in other chronic respiratory diseases which are associated with breathlessness as well? So carrying on what this gentleman pointed here is. Yeah.
That's a really good question, and to be honest, I don't think we know. So Dan's study that I mentioned was a small study. It only had 15 people in each group, and that was looking at balance in people who'd undergone thoracic surgery for lung cancer. As far as I'm aware, there hasn't been any studies done looking specifically at balance in people with bronchiectasis, which is something that we might be considering looking at, or in people with asthma. Of course, we know that balance is impaired in the older population, but I do think it's different in people with COPD. So we know that as we get older, we tend to transfer our balance strategies up to our thoracic region, and I think in our trunk. So this is why we see more movement, more sway around the hips as we get older and we're trying to balance. And that's an effective balance strategy. That means that people don't fall as much. But in people with COPD, I think it's very difficult for them to do that because of this pain and stiffening that they get around this thoracic region. That might be quite similar in a chronic pain population, to be honest. But I guess to answer your question, we don't know. It's quite a novel area, I think, in respiratory diseases. And yeah, it'd be really interesting to do some more work.
Your findings may have application to other chronic respiratory diseases. So
Definitely. Particularly bronchiectasis, I think, would be really interesting to look at.
Yeah, idiopathic pulmonary fibrosis.
Mm-hmm. Yes, yeah.
Thank you.
Okay, one more question online, please.
Yeah. For general falls prevention, 50 hours of exercise has been proposed as an ideal dose. Has this been considered in balanced studies with people living with COPD?
I don't think it has in terms of duration and dosage. Balance training has usually been aligned with pulmonary rehab, which differs within different countries, but certainly where most of the work has been done in Canada, it's a 6-week programme, and pulmonary rehab is delivered twice a week during supervised sessions and once at home, so it's delivered 3 times a week. I'm not, off the top of my maths isn't very good, so off the top of my head I don't know how many hours that is, but that's really what we've delivered and known to be effective.
So, thank you, Sam.
Thank you very much.
It's been an
Thank you.
excellent evening, great talk. Perhaps you all could join me in thanking Sam for an excellent presentation one last time.
Thank you.